All right, that's it. Okay, let me just make this a bit smaller. So I can't see everyone's face now, so someone will have to talk if they want to stop and ask me a question, or put something on the chat box, I suppose. But thank you everyone for giving me an opportunity to speak today. I think Johan's done the introduction. This is a huge topic to talk about TMJ and TMD. So I thought it would be most useful to give a sort of grounding on some terminology and a little bit of an idea of how I think about it. If at any stage you want to stop me, please stop me and ask a question. If I speak too fast, stop me. I do that all the time. So just stop me and I'll repeat what I need to. So I think Johan did a very generous introduction. All my training is there. When I do TMJ surgery, we're in this lovely new building that was built a few years ago. Outside of work, I have 2 kids. We play on the beach a lot, and that's where we spend our weekends. And this is Sydney on probably the best day ever. So they took it on a helicopter. And roughly where this dot is where my practice is in relation to that photo, but obviously the photo doesn't cover it. So most of my current training or recent training was on TMJ surgery, but TMJ is a lot more than surgery. In fact, very few patients ever need any surgical intervention. And so I just put this picture up because this is the sort of thing I do, but it's certainly not the most common thing. So this is a girl with an osteochondroma of the jaw. She has a significant facial asymmetry. We took the little osteochondroma out and realigned her straight. But this is not what most of TMJ or TMD is. So what is the rest of it? And what's the things that we see every day in clinic? And how can you start having a bit of a method to think about it, I suppose, is really where we wanted to go. So as a dental student or as a dentist, what are the things that I think you should know? I think we have to have some basic understanding of the anatomy and the physiology of the joint and the muscles. A very common term we use in medicine is the musculoskeletal system. And sometimes I think we forget that the muscles act across the joint and they act in unison. So it's very important to be able to differentiate between pathologies of the 2 systems. There's a lot of confusion with terminology. And so I think it's good to have a way of writing notes and a way of communicating with colleagues, which may be different to the way that patients describe what we have. I think we need to have an understanding of the spectrum of diseases. So there are a lot of diseases encompassed within the term temporomandibular disorders. And I think that's really the key, is that the key to making a good outcome is really by making a good diagnosis. I'll talk about how I do the clinical history in the exam in my practice, and not everyone that I see needs surgery. The vast majority don't. So I think that that's a translatable skill. And I want to give you an idea of the spectrum of treatments that are available to the patient and how I think about moving through the different treatment options. And then an idea of what, as dentists, we do for treating these patients, and also to think about who else is involved in the care, because it's a spectrum of diseases, and maybe some of the indications as to when you refer patients to somebody else. So that's sort of what we want to go through today. So the anatomy is really important when we talk about the TMJ, because we need to have an idea of all of the structures that are around it so that it helps us make the diagnosis. So there are 2 bones. So there's the mandible and there's the base of skull, or the glenoid fossa. There's obviously muscles. So the muscles of mastication are the main ones. So the masseter, the temporalis, the pterygoids. But there are some accessory muscles such as the genial muscles and the suprahyoid muscles. And then when you look a little bit out from the zoom, there's always things like the neck, the sternocleidomastoid. So the muscles play a really important role. There's a disc within the joint, and you can have issues within the disc. And the term for that is internal derangement, but we'll come back to that. There's obviously like a capsule that the joint is inside, and that capsule is made up of a series of ligaments that are fused into one. And then there are ligaments that are out. So that's the ligaments that make up the capsule. Obviously, we all have ligaments like the stylomandibular ligament, which are outside of the joint itself. And then it's good to think about what else is around it. So the brain is above it, which is important when we're doing surgery. The ear is behind it, also good to know when you're doing surgery. You've got the coronoid process, and that can impact people's opening and closing. So that's good to think about, and that's anteriorly. There are nerves that are both medial and lateral, and then there's the big vessels, most notably the internal maxillary artery. There's also the superficial temporal artery, and it's just good to think about with other diagnoses such as temporal arteritis. And then there's all the nerves. And one key thing to remember is, unlike other places, the idea of central sensitization is very important in temporomandibular joint. And for those who don't know what that is, that's this concept that when you have chronic pain in one area, and it doesn't really matter where that area is, it could be from a tooth, it could be from the joint. After some time, there are physiological changes that happen in our C-spine, and then there are subsequent changes that happen in our brain, so that our view of what, or the way the brain interprets the inputs, changes over time. And so you can end up with things like allodynia or hyperesthesia. So things like a stimulus that would be normal to a person who doesn't have these diseases could feel painful to people who do. And then you get things like trigger points. So it's just important to remember it as one step further thinking about the nerves compared to, for example, like a dental problem where it's the pulp that's sensitized, or they have periapical lucency, and therefore the trigeminal nerve is affected. So it's just good to think about these nerves. So I think that's all. Like, you don't need to know a lot about the anatomy, except to realize that it's part of a system. And the joint is actually a joint on its own. It's a muscle on its own, irrespective of the teeth. So a very common misunderstanding, which was sadly pushed through happening in Sydney, is that all TMJ problems are related to teeth, which is not true. You can have TMJ problems without teeth. So it implies that the teeth are not really the fundamental problem with this joint. So I think this is probably the most important thing, couple of slides. So the first thing is, like, the terminology is really important. Patients come in and say things, and a lot of my patients come and say, I have TMJ. But the TMJ is not a disease, right? That's the joint. That's like saying I have a knee, or I have an ankle, or I have a wrist. So it's just a joint, just has a longer name with more letters, but it doesn't make it anything else. Then the second thing is this word temporomandibular disorders, or TMD. Lots of patients come and say that. That is also, we have to be careful about how we use that word, and I'll come in to talk about what that actually means. So temporomandibular disorders is not a disease. Like dental caries is a disease, chronic periodontitis is a disease, but TMD is not a disease. So we should really understand what that means. And I think that's a key concept that's taken a while for me even to understand. Then there's this word that often comes up, internal derangement. And that's a complicated word. And how I describe it to patients is that there is not smooth movement in the joint. So that encompasses a series of things like clicks, some crepitations in the joint, those things that they feel like it gets stuck and it gets unstuck, or it locks and it unlocks. They're all part of this sort of idea of derangement. Did someone have a question? No. Okay. Then there are myalgias, which are tender areas in isolated muscles that we can reproduce. So that could be pain in the masseter or pain in the temporalis. There's myofascial pain. So this is when the pain extends, and it may extend beyond the region in which the noxious stimuli, or where the initial pain is. And then there's arthritis, which means effectively that you have some inflammatory process that's happening in the joint. Again, arthritis is not a diagnosis, it's just a finding that we find. And then there are obviously many reasons why you may have arthritis. So one can be degenerative change, wearing out of the joint. You can have like an inflammatory joint disease, and there's lots of those like rheumatoid arthritis and ankylosing spondylitis. So again, there's a lot of these words that are not diseases on their own. And I think part of the problem with treating them historically or getting bad names for treating them is because people haven't made the right diagnosis. So let's go to that. So this is the most important thing, I think. TMD is not a disease. And I think that idea just helps us think about how we're going to manage them. So there's a few ways to think about it. So TMD is a group of musculoskeletal or neuromuscular conditions that involve the TMJs, the masticatory muscles, and all associated tissues. They don't have to involve any one or all of them, but it's just a term that sort of roughly means you've got pain around that area. And it's good to try and differentiate TMD from other things like headache disorders or dental pain, etc., and totally other unrelated things as well, which are cluster headaches and all those other sort of disorders. And so you want to look for something that sounds like they have pain, that they've got some sort of joint noises or restricted jaw function. So that means inability to open, inability to chew, or inability to speak and swallow. So you want to look for those sort of things, as well as some clinical evidence of pain on palpation, etc. So yeah, I'm repeating myself many times, but TMD is not a disease, so therefore there can't be, it's a group of diseases, so therefore there can't be one unifying treatment choice for everybody that walks in with facial pain. So I think if there's only one thing to take away from the lecture, then that probably is it. This is the current accepted sort of taxonomy of these diseases. It's freely available if anybody wants to look it up. It's getting on a little bit old. The person who wrote it is Chris Peck, who's the former dean of the dental school here in Sydney. And I think that this is, there's a lot of words, and you should probably go back and have a look when you get a chance. But again, so temporomandibular joint disorders, that you can have joint pain, like arthralgia, which is pain from the joint, or arthritis. But again, arthritis can have many different types of arthritis. You can have joint disorders. So joint disorders is problems with the disc effectively. And this is the other word is internal derangement that we talked about. And that's things like clicking, where a slightly displaced disc comes back, people with locking, people who can't open fully. So they're all problems that have a disc etiology usually. You can have non-disc related hypermobility. So people who can't open their mouth, that doesn't have to, they're not all related to the disc. So classic examples is people who have had previous scars, people who have had radiotherapy for cancer treatment. And when I did an elective in India, there's a lot of people who chew betel nut, and that causes some scarring of the buccal mucosa. They can't open their mouth fully because of habit changes. So there's a few things that can happen. Then there are adhesions and adherences inside the joint. So you can see that the first bit here is most of these, sorry, I should have said, there are joint problems, as this is generally related, muscle problems, headache, and other. So within just the joint problems, there are so many. So we need to go through them. And then there's a difference between people who can't open fully and people who are open too often or dislocating. So people who don't open fully are hypermobility, and they can have all of those things that we talked about. Then you can have the opposite problems, which is hypermobility, which is people who dislocate and keep dislocating. They keep turning up at the dentist or at the emergency department at the hospital to get their jaw put back in. And a true dislocation is a person who probably can't get the joint reduced by themselves, versus subluxations who are stuck out, but then they can get them back in. Usually the more time someone dislocates, the more likely they can reduce it themselves also. So there's joint pain, there's joint disorders, which may or may not have pain associated with it. Then there are actual diseases of the joint. So osteoarthrosis, is just a degenerative disease, and arthritis is when they also have inflammation. And then all of the systemic things that we can have, rheumatoid arthritis, blah, blah, blah. And the rest of this is all a bit rare, but you just need to know that it exists. Things like that lady that I showed you, like osteochondromas, and you can get cancers there and things, but they're all quite rare. You can obviously have trauma. Don't worry about the congenital stuff, probably not related. Then there's a whole group of other problems which are muscle-related problems. And I think they're really important to understand that there's a difference, because you shouldn't have the same treatment for your joint as you do for your muscle. Then there are people who have headaches. And really the key question when you have somebody with headaches that comes to your practice is to ask, is chewing or moving your jaw joint increasing or decreasing your headache? Because then you may have to do some sort of TMD management. And I think, so forget about the rest. But so I think this is not that you need to memorize all of these things, but just to understand that TMD has a lot of different diagnoses within it. And really the way to try and get good treatment outcomes is to try and work out what the actual problem is. This is done very poorly, by the way, everywhere. So then, you know, at least in Australia, like so many people, I put this list together in about 2 or 3 minutes this afternoon. And I was just thinking, who are the type of people that I get referrals from, or that I know that treat TMD? And the number is huge. So we've got dentists to do it, orthodontists, prosthodontists, we have oral medicine specialists, we have maxillofacial surgeons like myself. There are some ENT surgeons and facial nerve specialists that look after it. There's lots of neurologists, lots of people that call TMD a part of sleep disorders that treat it. And then we have all of the allied health type people, so physiotherapists, occupational therapists, exercise physiologists, acupuncturists, dry needling, chiropractor, registered nurses who inject Botox. So there's a gamut of people who try and solve the problem, and no one is really like necessarily treating everyone well. And the reason is this, is that people haven't gone back and tried to work out exactly what the diagnosis is. So I think it's a key concept. Probably everyone has a role, like there's no one here that's like useless, but I think the key thing is to make sure that we don't just, if you have one tool that you can't use that one tool on every single patient. So most of TMD is about trying to find out who needs what treatment and whether the treatment that you offer works for that patient. So the epidemiology, at least in sort of Australia and the Western world, is that lots of people have TMD. They come and go. 25% of people will report symptoms probably at any given time or any given year. About 4 or 5% will seek treatment. So that's really common. Females are about 4 times as likely to present as males. We don't really know what the incidence of symptoms is, because all of the surveys and studies are when patients come into the doctor's office. But we definitely, even in my practice, there's a lot more females than males at the younger. Once you get past about 40 years of age, that number seems to even out a little bit more. And we're not exactly sure why that is, but it's probably related to things like rheumatoid arthritis, and some of those other disorders are far more common in females than males, some of those autoimmune disorders. So the most common things I see in practice, myofascial pain or myalgia with some dysfunction. I see a lot of internal derangement, and then I see a lot of degenerative disorders. So they're the 3 most common in my practice, and I'm sure it'll be the 3 most common in most general practices around the world. So we've said that there's lots of different potential diagnoses. So it's important to have a standardized exam technique so that you can try and differentiate some of them. It's really important to have a history that will help you work it out. And then just remember that the goal of history and exam is then to drive your investigations, have a provisional diagnosis. So you should have some sort of diagnosis that you're working to, and therefore try to prognosticate various interventions. So is this going to work or is it not going to work? So we can say to our patients, you know, we should try this, or this is most likely going to work. You should have some sort of idea of the success rate. And then if possible, we want to assess our own outcomes of managing our patients over time. Now, the history and exam, again, I think it's a little bit more complex than with common dental diseases such as dental caries or endodontic diseases, just because it's more difficult to localize and there's just more tissues. So again, this is a freely available resource that you can get. So it's the RCDMT, sorry, the DCTMD questionnaires, and there's lots of them, and you probably should read it. I've put little arrows when you guys get the notes to see which bits of it I use. Like I find some of it, all of it just too much. So I use some of these that the patients go through. So effectively, there's a basic questionnaire that goes through how long they've had pain for, where is their pain, do they have headaches, do they have locking, which means can't open their mouth, and did they get dislocations, so that you can start working out where the problem may be. We normally do a pain drawing. So the patient has a pencil and they can either mark X or circle or shade on the person's face and neck and body where they have pain. So is it really in the face, or do they have neck pain and body pain and lots of other pains, which means that nothing that we do is really going to help. Like they may have to go somebody else, see somebody else. There's a graded chronic pain scale. So, you can ask the patients these questions. They don't have to fill themselves out. But in my practice, this all gets emailed to the patient and the patients fill it before they come in. But it effectively asks like, how many days have you had pain? And then the impact of the pain on living. So because of pain, can you not eat? Because of pain, can you not go to work? Because of pain, is there other things you can't do in your life? And then there's some health questionnaires, some oral behaviors checklists, which ask them things like, are they chewing too much? Do they lie on it? Do they do any other activities that could make it worse? And then there's a mental health questionnaire, which really asks about depression and anxiety. So a lot of people, depression, anxiety, and suicidal thoughts and things, because there's a big mix of these. A lot of these patients that we see also have things like depression. And this TMD sort of spectrum, it overlaps with a few other medical diseases or syndromes that we see. And this includes things like irritable bowel disease. There's a lot of patients who have tinnitus or hearing sounds in their ear. There's a sequence of patients who have balance problems. So they're sort of every medical specialist seems to see a few patients who are a little bit difficult to sort out. They also have depression, and TMD sort of fits into that thing. So it's good to always ask about the mental well-being of the patient. So my patients all fill out those questionnaires. And in addition to the standard questionnaires, which you can all download and have a look when you have time, I always ask about these are the things that are not in the questionnaire that I think should be in the questionnaire. So I always ask about any previous treatment they've had, any previous diagnoses that have been made for them. And maybe because I'm more surgically inclined, we always ask about previous trauma. Like, have you been in a motor vehicle accident or fallen from a height? Have you had recurrent ear infections as a child? Because those things are more likely to result in TMJ ankylosis, or a bony fusion between a bony or fibrous union between the condylar head and the glenoid fossa. So they're sort of things that I ask. I also always ask about any rheumatological and autoimmune conditions. So oligoarthropathies, things like psoriasis. I always ask about polyarthropathies. So the two big ones being rheumatoid arthritis in women and ankylosing spondylitis in men. And when you have those two diseases, you can always have TMJ disease. There's also another condition called juvenile inflammatory arthropathy, and they're people who are probably going to become rheumatoid patients as they get older, although not all of them have rheumatoid factor. So we always ask about that in adolescents that present. And it's good to think about things like chronic fatigue syndrome. So these patients often have muscle pain or muscle fatigue everywhere in the body. I don't think anyone has found out why this chronic fatigue syndrome exists, but there's probably, something that medicine will find in the future. But when you have a TMD patient who has chronic fatigue syndrome, they're very difficult to treat with anything that we do in the mouth, head and neck. I always ask about some specific occlusion histories. So I always ask check if they've had lots of teeth missing, and therefore their bite is not sound. And then if they said, oh, yeah, I had to have 7, 8, 9 teeth taken out, or I don't have any back teeth anymore, usually like their joint, and if their joint problems start sometime after they've lost their teeth, so, you know, in the 2-3 years after they've lost their teeth, it could just be a problem that they're over closing all the time. So that's important to ask. It's always important to ask about any previous orthodontic or orthognathic treatment, which is moving of the jaws. And that's because we often see that when people are having things like braces, they have a short period where they get TM joint pain. And that makes complete sense. When an orthodontist moves teeth, not all the teeth are touching all the time. So if only one tooth is touching, it's like walking on one toe, and you do it all the time. Eventually that toe is going to hurt. So, and usually it stops. So when the orthodontic treatment finishes, usually it comes back over time. So there's no reason to treat them particularly fast. And then the last thing to think about is things like social stresses. Has anything been worrying them in life recently? Because a lot of these people clench and grind. We see a lot of university students who clench their jaw around the time of the exam, they get pain. There was a lot of people who had these sort of problems around COVID time and COVID isolation, who were clenching or started picking up new habits like chewing gum for hours on end. And so it's always good to ask about what have they been doing different recently since the pain started. So you can use those standard questionnaires too, but these are the things that I think are missing in those questionnaires if you wanted to ask the patient those history. This is the examination chart I use. Again, this is freely available on that DCTMD website, so you can download it. Sorry for the yelling in the back. That's just my son hitting the shower. So this is the exam that we use, the patient, your name, the date that you've done it, so that you can do it many times. And I'll let you look at this through this slowly, but effectively it goes through the pain, their occlusion, how they open their jaw, how far they can open, how far they can move the jaw from left, right, and forward. This goes through clicks when they're opening, closing, crepitus, which is like a grinding noise. You can do crepitus with your finger. You can also hear it with a stethoscope if you have one. Joint locking, which is the inability to open or open beyond a certain point. And this is testing of all of the muscles. There's actually like an instruction sheet as well on that website of actually how to do this. But I effectively just follow this order, and I get my dental assistant to tick yes and no as I go along. And then at the end of it, we try and get to a diagnosis. So a pain diagnosis, a right TMJ diagnosis, and a left TMJ diagnosis. So I won't go through that in a lot of depth because I think it's all written down on the website, but this is exactly the form that I use so that it's standardized every time the patient comes in and for every patient. The things that I do additional to that, so one of the little issues that I notice is, even though this says, do they have pain on the muscle? It doesn't really tell you how much. So I usually make a little note of how tender they are, like plus, 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 plus. Usually plus means they say, oh yeah, that's sore. 2 means that, you know, they wince a bit, like, you know, they look like they're in discomfort. And 3 is when they've had a significant amount of pain. I created a visual analog diet score, which I'm happy to share, but I think it needs to be sort of regional specific. So I have a piece of paper in my clinic where 0 is like water, 10 I think is chewing on like, you know, rare steak, and, you know, 9 is nuts, and 8 is crusty bread, 7 is cooked vegetables, and so on and so forth. So the patient can circle or tell me the thing that they can eat comfortably. So if, for example, you can eat cooked vegetables, but you can't eat nuts, that gives them like a score of 7 out of 10. And again, this is just a tool to see how well they're chewing. Because in the questionnaires, there is a diet score, but it's very hard to compare one patient to another. Like my 7 out of 10, maybe someone else's 8 out of 10. So it's good to have some sort of idea of how much their diet is affected. And when you're doing your examinations, apart from just the tenderness, which is on this side, it's good to see whether the masseter muscle and the temporalis muscles are really hypertrophied or big. And usually that's just a little clue that that person may clench or grind too much. Some people use an ultrasound. I'm not really sure that that's necessary, but that's just a good thing. And to go with that, so somebody who clenches and grinds too much will have very powerful masseter muscles, very powerful temporalis muscles. The other things that they will have is evidence of occlusal wear. So that's when the teeth are flattened, and just it's a very obvious thing, but just a thing to think about is if your teeth are worn and all your cusps are flattened, that usually means you're grinding, which means that you're moving your jaw from side to side. There are also some people who have really powerful muscles, but no occlusal wear, but they have fractured teeth. So they are what we just call clenchers. So they're just biting their teeth together and clenching hard. And usually by the time they're sort of 40 to 50 years of age, they start fracturing teeth. So that's also a problem. Look in the buccal mucosa and on the side of the tongue, and you can see that white line where they've been chewing on their cheek or tongue all the time. Look for missing teeth, and look for CR discrepancy. So that's a difference in between where the jaw joint is comfortably, like centric relation, and centric occlusion where the teeth meet. That's most common in people who've lost their back teeth. So if you've lost your molar teeth and your molar teeth don't meet, you overclose your jaw to get the front teeth to meet, or you protrude your bottom jaw beyond normal range all the time to chew, and also you use your front teeth to chew. So that changes the way your jaw joint is loaded, and therefore they can also have pain. So these are the little things that I make a note of. Just like the history section, I think that the official world questionnaires are missing things. I think the examination, these are the things that they're missing that I take a note of in my exam. Imaging of a TMJ. So this is sort of, we've talked about history, we've talked about exam. Imaging, the most basic screening test is an OPG X-ray. It only shows you something about the condylar head. So it won't give you any information really about the glenoid fossa, and it can't really tell you anything about functioning, because when we do the OPG, you know, they bite on that little plastic thing in the machine. So you can't really tell anything about, are they opening, closing, locking, and so forth. If you think that they need more imaging than an OPG, you can get plain film TMJ views, and normally they do them open and closed. So you can tell if one jaw joint is opening more than another jaw joint. If you're worried about the bony head and you think they've got arthritis, etc., you know, that's probably starting to be a time when you're also thinking about referral to a specialist, but a CT is usually the best thing. And then to look at the soft tissue and the ligaments and all that is MRI. And then if you really want to see the joint, we do this sort of thing where we put a camera inside the joint and have a look. And that's the most predictable way of looking for things like holes or adhesions in the joint. Does anyone have any questions? I feel like that's already a lot of information. Or can I continue? Oh, there's something in the chat.
I have a question.
Yeah.
If I may. In PNG, and I'm sure Jebby and the doctors can elaborate on this more, but there's quite a long waiting list for a lot of the imaging facilities.
Yeah.
Is there something that perhaps can be done in the dental clinic? And Jebby, I'm not sure whether all the dental clinics have OPGs or just bite wings or what they have there, but is there a way of clinically assessing it with sort of visual inspection or palpation or something like that that could give you a bit more of an idea than just, you know, generalized pain without having to go to a CT?
Yeah. Yep. So if I just go back to that exam section, sorry, where's my? So when you're doing the exam, there are a lot of clues. So one, you're looking for things like, is their face asymmetrical? But two, you can look at things like, what is the opening pattern? So, I mean, you could, when you will all have a clearer version, but it says like straight or corrected or uncorrected. So usually if someone has a left jaw joint problem, then that side doesn't move as well. So if you can imagine that your left jaw joint is now painful or not moving well, then the right jaw joint is moving normal. So actually, let's go back even a bit more. That's a good point. If we go back to this picture, the way a jaw joint opens is really important to understand. So when we open our mouth, what happens? So there's minimal muscles, right? Like most of the muscles are for closing. So to open, we don't really have much, a little bit of the lateral pterygoid, a little bit of the muscles of our chin, right? The genial muscles and the suprahyoid muscles. But when we open, the first 20 millimeters or 2 finger breadths between our front teeth, the first bit of opening is really this rotating. So this bottom bit is just, it's not moving anywhere, it's rotating. So it's rotating that way. And that means that it's happening in this joint space, right? The next significant opening, this is rotated now, it can't rotate anymore, is it's starting to come along, this whole section is moving down here, right? And so if you can imagine a normal jaw joint, it rotates and then it slides. It's not perfectly one then the next, but you know what I mean, like roughly. So when people have significant problems, often they can only open, this bit works. If you've got a problem here, which is a more common place to have a problem, this bit works, that bit doesn't work. So you can rotate and open 20 millimeters between your front teeth, but you can't open beyond 20. So normal for an average size Australian female is about 40 to 45. For an average size Australian male is about 45 to 48, something like that, millimeters between your upper incisor teeth and your lower incisor teeth. So now if you think about now the jaw joint, the jaw, the mandible, is an interesting bone because it's connected to the same bone on either side. So it's connected to this temporal bone. So it's not like a, you know, like your humerus is like got your elbow and your shoulder, or you know, you pick your tibia in your leg and it's got the knee above and it's got your ankle below, but this is sort of connecting around. So if you think about a jaw and if one side is got disease, so let's just say this person's left side has caused disease, this doesn't move. When the right side, when you open with those people, the jaw will swing towards the side where there's a problem. Does that make sense? So your jaw will open in a pattern towards the side that you have pain or restriction. So they're the sort of clinical exam things that you want to look at. So if you've got like a serious lock or a serious problem on the left side, the mandibular chin point will swing towards the left. If you've got internal derangement and a click, it corrects. What happens is it starts moving towards the left, then it will correct to the normal. So the jaw will open in a pattern. And if I go back to your exam sheet, the jaw will always open in a pattern towards the side of a disease, typically. So you can exam, you can palpate, they could have pain, all those sort of things. And then this sort of stuff is very important, just measuring how far they can open, which way they can open. So to move the jaw to the right, your left joint needs to be good. To move the joint to the left, your right joint needs to be good. And to be able to protrude your teeth, you need both of your joints to be in good condition. So if you think about how far you can open and which way they can move, you can often isolate which joint has worse disease without the need for an X-ray, but the X-ray confirms it. But it's a very deep joint. It's not like examining a knee, unfortunately. It's not as straightforward to examine TM joint as it is to examine a knee or a hip in terms of all those other things. All we can do is range of motion. So, you know, usually we need some sort of imaging in addition to the other problems. Is that all right, Johan? Does that answer?
Thanks, that was very helpful.
Yeah. And obviously, like, you know, you've got to think about, like, can we treat all these problems? You know, these are, yeah, you know, it's all getting very subtle by the time you get to this scope sort of area. So, you know, this is still not available in large parts of the world. And even in, like, in my state in New South Wales, there's about 3 of us that know how to do these procedures. So it's not a very common thing that's done everywhere to do things like arthroscopies. And even reading MRIs, there's not that many people, even in Sydney, who read an MRI well. So even though you can have access to them, even if you had access to the machine, the problem is not the machine. The problem is finding people who can reliably read them. And when I was in England and we were using a general radiologist to read our MRIs, we found that, like, for example, like this is like, you know, you got a perforation or a hole in the disc. The MRI had about a 50% accuracy like the person reading it has about a 50% accuracy. So anyway, so I think it is good to have some access to basic views. It's not absolutely necessary for everyone, but I think it's a difficult joint to get all the information just from examining. This is again in the DCTMD. I've just put it up there just to show you that like there is actually a way to get to all those diagnoses. So on the bottom of this examination sheet, you're expected to then have a pain disorder, a diagnosis, and a diagnosis. And there is actually like a structured way of, okay, they've got muscle pain. Do they have any headaches? No, they don't have a headache. Can I confirm the location of the pain? So can I like press on the masseter and they said, yep, that's the pain. All right, well, yes. So then you can come in and then you say, is the pain that happened when I pressed it the pain that you often feel? Like, is it the same or is it completely different? And if they say like, yes, then you've got a myalgia. So there is a like, you just need to be able to work through it. Like you can have it printed somewhere, but you know, it's, this looks very daunting and overwhelming, but but you know, you've got this little history, then the exam and the diagnosis. And so there is a way of working through this to try and get to the right diagnosis. And again, you'll see that there's, if the person in the very first questionnaire had headache symptoms, you go through the headache bit. If they have like clicking and things, then you go through this algorithm, the internal joint disorder algorithm. If people are just old and they have crunching, you know, you go through here, and subluxation is when they have a problem of open lock. So the problem is that they open too far and they can't close their jaw. So this is the people who can't close. This is typically the people who can't open at some point in time. And so there is a little bit, and as you can see at the end, you do end up needing some sort of imaging, unfortunately, to get a final diagnosis of that. So treatments. So if I go back to like the one point I really just wanted everyone to get is that if you want any of your treatments to work, it depends on like getting the diagnosis right. People do this all the time. So I still find this the hardest part of management is actually getting the right diagnosis. I can tell you that there's, if you read the books say that there's something called the biopsychosocial model, which is that these patients are complicated because they have a biology, which they may have a disease like rheumatoid disease or degenerative disease. But there's a lot of people in this group that have psychological and social problems, things like depression and anxiety and things and social stresses and circumstances. And sometimes it's just good to know that because not all our treatments always work. If the person has a underlying stress or mental disease, you know, nothing that we do dentally is going to sort them out. And there are people who say that this is not true and everything is like biological disease. I'm not so sure. A lot of these people just improve with time. So a lot of people with mild disease, the most important thing you need to say to them is like the people who the problem is not opening and locking and they haven't had, you know, a cancer or a trauma. Many of these people just improve with time, and just reassuring them that they will improve with time is really important. A lot of people, I don't know what the culture is in your country, but in certain Asian countries, it's not very common, for example, for men to talk about their problems. And so they internalize it and they tend to get more of these problems where they clench and they grind. And it's just one manifestation of stress. I think no matter where people live, there are like stresses in life, and one manifestation of that stress is clenching and grinding. Other people develop other sort of habits. Some people call it depression. Some people get anxiety. When the tsunami happened around Sri Lanka, men suddenly had high rates of heart attacks. So they were sort of displaying it in a different way. So I think that we're not robots. We're all people. And like, this is definitely a sort of difficult group. So just remember that. And it means it makes your life easier. You're not expected to know all the answers and have all the solutions for all these patients. And you can possibly treat a small part of it, which is the biology. You can make them aware of the psychology of it, but, you know, we're never going to go and live with our patients and make their lives better. So, you know, you've just got to sort of think about, you're doing the bits of the treatment that you can do. Some of the approaches that I've heard, I've got some colleagues close to where I work. They do what I call the machine gun approach, which is do every treatment that's known for TMD and hope that one of them works. I think that's a very bad way of doing it. It costs a lot of money. It requires a lot of resources. It's just generally not a good way of doing it. I like to think about conservative to aggressive approach in general. Start with the things that are the least likely to have a bad outcome for the patient. This is a common thing where we are profitable intervention exhaustion. So there are some dentists and other specialists around here who'll do all sorts of strange and expensive treatment for patients who never get better. And then when nothing else works, then they send it to me. And all they may have had is like a closed lock or something, which I can fix in an afternoon. So it's just, yeah, these patients are vulnerable, and often they come to the doctor and they're sort of happy to have, they just want some reassurance or something, but they're also, they can be, sadly, some of these patients can be manipulated. So it's just a thing to think about with these. And you've got to have your own approach that you're comfortable with the ethics of. This may sound a bit strange for the dental students here, but it's a real sort of issue, at least where I am. So have a little philosophy of how you're going to treat these patients. And then let's talk about some of the treatments. And again, the spectrum of treatment is very big. So the first starts with watch and wait. A lot of people who have mild myofascial pain, or they have some social stress, something bad happened, they're, in Australia, we have bushfires, their house burnt down, suddenly they're clenching or grinding, or, COVID happens and they're locked inside their house. You've just got to reassure them that it's going to get better, and that they'll just have to come back to you if it's not getting better. So a lot of patients are watch and wait, particularly young patients. Unless there's a real biological problem I can see, if they're under the age of 30, I almost never do anything, because at that age, they've still got some healing capacity. So even if they've got a soft tissue problem or a cartilage problem, they can still heal. If they're in their teenage years, the bone can remodel, things can happen. So try not to be aggressive. A lot of these patients just need reassurance, and you say, I'm here if you need me. That's important. Patient education is just to sort of, explain the anatomy, explain why they have a click, what the click is and how it may go away. That sort of helps. I use physical therapy quite a lot. So I do a bit of explanation on how to, massage the muscles, but we also have a physiotherapist locally who teaches them. So often, we've all had like a crook neck or something after a day of dentistry, or, your back is in spasm, and, when you press those pressure points and it releases. So often people have those sort of pressure points in the masseter or the temporalis. So you can just teach them yourself on how to do that. And usually what I say is, use like a wheat pack or hot water or hot shower. And then when the muscle is a bit more relaxed, you massage it firmly with a lot of force in the point where it hurts. And usually that releases those sort of little muscle knots, and they feel better. If the simple things I teach them is not enough, I send them to the physiotherapist. All the evidence for these sort of things, so physiotherapy, which you can also call like manual therapy, then there's acupuncture, chiropractor. It's very hard when you read the research in the world of which is the best, and that's because it's probably dependent on that individual person, like the individual physiotherapist, how they do that manual therapy, but also like the way they behave, like acknowledging that the patient has a problem, etc. So all of them have roughly equal efficacy if you read the literature. And it's partly, I think you need to have a bit of a relationship with the people that also work in your team and see if that person will get along with the patient. There's medical therapies. So you can use topical non-steroidal anti-inflammatories. So that's something like, in Australia, the brand is Voltaren. I'm not sure what it is there. Or it's like a diclofenac ointment. And typically it's used on the knee or the hip for older patients with arthritis, but you can use it in your TM joint as well. So the way I instruct the patients to use the ointment is first to try a bit on their face, because the ointment is really made for the thick skin of your legs and your back, not really for your face. So some patients can get a reaction. So you test a little bit first, or the patient tests it to make sure they don't get a rash. But then usually you can put it just over your joint where you can feel your joint in front of your ear. But also if you all put your finger on your condyle where you can feel your joint and you open wide, you'll feel that there's a little divot behind the joint. And so that divot is really where you want the ointment to go, because, you know, that's roughly the area where the retrodiscal tissues and all the nerve fibers and things are there. There's injected therapy, which is things like Botox, which I do some of, but not a lot. It's very, very expensive. So that's usually the problem with it. Patients become reliant on it. So I don't really like it, but I use it in some rare instances. And then there's the medications that you can take as tablets. So you can take non-steroidal anti-inflammatories as a tablet if they've got arthralgia. So it doesn't really work. It works a little bit for the muscles. It really works for the patients that you've got an arthralgia diagnosis. And usually I use a COX-2 inhibitor. So that's celecoxib. And I use something like 100 milligrams twice daily. And I usually make them do it for 7 to 10 days to reduce the inflammation. For patients who have complex myofascial pain, I usually start them on a tricyclic antidepressant. So that's something like amitriptyline, but then they have to go back to their regular doctor or neurologist to manage it, because those drugs you have to keep. It's not good as a dentist to use them because you've got to keep seeing them every week or two, and you've got to increase the dose, and then you have to stabilize the dose. And then after a number of months, you have to decrease the dose. And it's really like, I feel like that's not in our core area of expertise, but, and also like we just don't have the time because there's so much dental disease to be dealing with. But it's not a bad thing necessarily to start them on a low dose of amitriptyline and then say, you need to go see a doctor and they can manage the drugs going up and down. There's lots of evidence now for these SNRIs, which are a group of antidepressant drugs. I recommend them really only when they've also got, when they do actually have depression, or they've got anxiety, depression or anxiety. And obviously that questionnaire that we talked about, if they score a high number, so, it's out of 12, but if they're scoring 6 or more out of 12, you probably want them to see their doctor and recommend they chat to their doctor about an SNRI. There's another group of drugs called SSRIs, which are a little bit older type of antidepressants. I've just put that there because some patients who start SSRIs I don't really know why, but they start getting sort of mesenteric spasms, so they can start developing TMD or TMJ type symptoms after they started the drug. And so if you notice that in the history, then you can ask them to go to the doctor and switch to an SNRI. So these are sort of our very minimally invasive treatments. Not much can usually go wrong when you do those sort of things. Where, as a dentist, the main sort of thing I think I was taught at dental school was dental orthotic devices. I'll come back and I've got a slide on that. Occlusion changes, which is a thing that was very popular, particularly where I am in Sydney, was to do lots of crowns and bridges and opening the vertical dimension of occlusion. I think that is all no longer really accepted. So I think there may be a very rare circumstance when the patient needs that, but in general, I think that was sort of a money-making scheme rather than a truly like beneficial medical intervention. And then the last sort of things is the sort of things I do, which is you just need to know that they exist, but you probably don't need to know much more. But we sometimes wash out the joint and put medicaments such as steroids or so the lubricating things in the joint. We sometimes put things like blood in the joint, blah, blah, blah. We can put a camera in the joint. You can do little operations using the camera, which is if they've got like fibrosis or ankylosis, you can burn through them. And you can do obviously open surgery, which is where you open the TM joint, and you can work on any of those bits of the joint that we talked about. But you just need to know that they're sort of for people who are later down the line. And the vast majority of patients actually don't need any of those sort of things. So that's a lot of treatments for a group of diseases. So, how do you choose? I think the first thing is make a diagnosis, have a bit of a workflow of how you're going to try the different interventions. It's not always clear cut which one you need to do, but you need to start with one, and if it doesn't work, go to the other. Also have a think about, am I the best person to treat this person? If they've really got a headache disorder, or if they've got auras, which is like a headache and they see shining lights and things like that, there's no point. Just send them to the neurologist. off the bat. If they've got this myofascial pain where all of their muscles are a bit sore and all of them are a bit tight, they're probably going to need more than one person to help them. Like they may need you for an orthotic, but they're probably also going to have to see a physiotherapist or whatever other adjunctive local treatments are available. And so I think it's good to tell the patients very early that you may need to try 2 or 3 things, or you may need 2 different treatments to help work with that myofascial pain. If they've got depressive illnesses or anxiety illnesses, just send them to the general medical practitioner or to a psychiatrist or something for those sort of people. Like I think there's no point trying to cure them with dental treatment. And if there's a true TMJ problem, like they're locking, they can't open, they're dislocating all the time, it's probably reasonable to send them to a surgeon. If you think it's helpful, you can make a little orthotic. So here's my little, so, you know, I don't make the orthotics myself. Like I get the dentist to make them now because I don't have the time to keep modifying them, but there's lots and lots of different orthotics. If you're not sure which one to use, you can ask your local surgeon if they have a preference. Usually when I see a patient, I write a prescription for the dentist to follow on what sort of orthotic to do. But so here are my principles of dental orthotics. So first, don't do any harm. So don't do this bottom right picture. That's a disaster, right? Especially in the wrong patient. And if you do this long term, the person's going to get a problem because you're putting all of the weight of the occlusion onto 2 teeth. So people do these sort of things because they say they're capturing the disc and they're stopping clicks and things. I'm not entirely sure. And I think unless you're really confident, you shouldn't be doing these sort of things. This sort of splint it's called a Michigan splint. It's hard. It's probably the way to go. If you're not sure and you have no idea, make a Michigan splint, right? Little things to think about. If they're a person who grinds their teeth all the time, so you can see all their teeth are worn out from constant rubbing, you can make a slightly softer splint because if it's softer and the teeth are biting into it, it's less likely to be moving. So, so that's called a non-permissive splint where they have little grooves for both the upper teeth. So these splints, sorry, this picture shows like it's on the upper teeth, but you can make this the other way around. It doesn't matter whether it's top or bottom teeth, whichever one you're comfortable making and whichever one the patient's comfortable with. If it's non-permissive, that means it doesn't allow them to move from side to side. So you have to have the indentations of the teeth from the opposing arch, maybe a little bit soft. If they're a person who clenches, like those people that we said, 40, breaking their teeth, biting hard, strong messages, you don't want to give them something soft because they'll just chew on it more and more. So yeah, that's when you do soft and hard. In general, it's good to wear them for 8 to 10 weeks every night. And then after that, intermittently, because your brain gets used to it. It's like wearing new shoes or new clothes. After some time, you get used to it. So it's better after about 10 weeks, unless the patient really feels like they want to wear it every night. You can have them wear it every second night or 2 out of 3 nights or something like that. And the main reason I say that is because you don't want unexpected orthodontic change or movement of the teeth. You don't want unexpected TMJ problems from loading the joint in a weird way. And these splints also need to be modified. So when you make it and the muscles start to relax, you'll see when you use the articulating paper that in a few weeks or months, they start biting on different places. So you always want to make sure that when you have this, you put some articulating paper to test it, and they're biting on sort of all of, particularly the back teeth on both sides, but even a little bit across the front. You want to make sure they have even contact in all of those places, and it changes over time. So these are not, you can't issue them once and then forget about them forever. They need like remodification. And like I said, if you're unsure, ask someone for help because these can do harm. They look very benign, like it doesn't look like it's surgery, doesn't look like anything bad, but you can cause problems. This doesn't have to be the first thing that you try. Like there's nothing wrong with sending the person away for physiotherapy and saying, come back and try a splint if that doesn't work. So some dentists think that this has to be provided for every single patient with any type of TMD, and that's probably not true. Occlusal changes, I would just say don't do them unless you're asked to do them by somebody else or you have a group consensus with an orthodontist or a prosthodontist. So occlusal changes is like when they build up all the lower teeth or they extract some teeth or they put crowns on certain teeth or build them up. Like it's very unlikely because a lot of people have teeth and a lot of people have TMD And some people, the teeth don't change, but the TMD comes and goes. So I'm not sure that the occlusion is always the cause of TMD. So just be wary. In certain cases, like I said before, if people are missing all their back teeth, then sometimes it's good just to give them dentures so they have their teeth and they have a more even occlusion. But in general, occlusion changes for TMD is no longer considered sort of accepted treatment. That was really it on my dental orthotic. Has anyone got any questions? So it's a lot of information, but I just want to try to set an overview for what is a very, very big topic.
Thanks, Dr. Krish. We might open the floor to any questions. I noticed a few more people have joined us whilst you're presenting, Krish. We have Dr. Bradley, who is a resident, and Dr. Posolok, who is one of the senior dentists in PNG. So thank you guys for joining.
You're welcome. Sorry, just a correction. I'm not a senior dentist. It's just my first year of practice. So.
Well, thank you for joining.
No problem. No problem. Thank you very much.
Was it all too much information? It's not really a topic that's taught in a day because there's so many different diseases. I think the main thing is just to understand that it's a group of diseases and that there's sort of, there's little treatments and how you decide on each one on its own. I've tried to make it simple, but I've realized there's no simple way of making it simple.
Debbie, do you have any questions?
I've bamboozled everyone.
And that's good.
No. So yeah, so I'll if you all get the slides, you can go through that website and download those forms. You can look at them at your own time. And I think that's helpful because it goes through how to do the exam, how hard you have to push on the face to see whether someone's tender, etc.
Can I say something?
Yeah.
Thank you for this presentation. It really did clear up a lot of things because we usually just do a blanket diagnosis of TMD without really understanding that there's so many causes of TMD itself, and it's just a blanket term. I think what was helpful today for me is the chart, the examination sheet and the chart. I think we'll try and check on it just to make sure that we are diagnosing our patients appropriately. In the practice, while being out, I've come across several patients. The majority of patients who come with TMD post mandible fractures. We see a lot of mandible fractures, especially in the highlands. And they, after the treatment of reductions and all of that, they complain of pain, or there's also myofascial pain. So yes, for the treatment here, we tell them that we only do the physical component of it. As stated, we don't have CT scan or any of that to help. So our OPG, yes, we do have one. We do use it, but it's not really, it doesn't really help us at most times to diagnose what's actually happening. So what we usually tell our patients is to do the heat compress and mostly physio. We sit the patients down and we talk to them about physio and basically just putting a hot material on it and just massaging it down. And then we call them, we put some anti-inflammatory most times, just put them for a week, and then we assess them. But majority of the patients that come also come because of trismus. They cannot open their mouth. Then they come to the clinic. So that's what we usually do here. But I think what was helpful with the presentation is we'll try to get the diagnosing examination sheet just to help us have a clarification of what actually is causing the TMD. Is it because of the muscles or the joint itself or the bones and all of that? So I think we learned that today, and for that, thank you for the presentation.
Yeah,
Yes.
so it's interesting that you say that. So if I think from what you just said with those trauma patients, so one way you can tell whether it's the joint or the muscle, apart from the X-ray, is when they're opening, they have limited opening or they have trismus. What you want to see is if there's a difference between what they can do themselves. If you say, how far can you open? And you measure that distance, and then when you help them. So when they do it themselves, it's called active. And when you try and open their mouth, it's called passive. And what stops the passive movement? So if it feels like a hard wood end, there's something like anatomically wrong, isn't it? Like something is stuck. Yeah. But if it's pain, it's more likely, if it's pain that's stopping them and they say, ow, ow, it's sore, you can then say, where is it? And so you can actually differentiate whether it's in the jaw joint or the muscle. So that's one thing to think about, because with the mandibular fractures, about half of them are going to involve, so half of mandibular fractures involve a second site, not just one site. And most commonly, that second site is usually around the TM joint. And so once those patients have been fixed with wires or plates or screws or whatever they are, and that initial period of healing is over, it's really important that they have a lot of active physiotherapy early. They have to keep it moving. It's no different to any other joint. And if they don't, then all the blood causes them to get a bony ankylosis and they'll get stuck. So that's not uncommon at all. And that's not a thing that we thankfully see too often here, because like every person gets a CT and things like that. But I think it's if there's one thing you can do is make sure that they're opening and closing all the time, especially if you see them early after their fracture, because you want to keep their range of motion. Once they get that trismus, it's actually very hard to treat subsequently.
Thank you.
Welcome.
Thanks, Krish. I think there's another comment in the chat. This is from Beatrice. Our challenges here in the New Guinea Islands remain similar across the country. We have 2 public hospitals with OPG, about 3 major public hospitals with CT scan. The rest of us use normal digital x-rays or in our cases here. So my TMD examinations depending entirely on an in-depth history examination and an inter-team management. That's me, Dr. Solak.
Yeah, I mean, it's a challenge. Like, yeah, I can imagine it's a challenge. Like, yeah, I've obviously we probably have a very high reliance on all these other imaging things, like where I work, right? And most of the patients I get sent to me already come with imaging, so I can imagine that it's a challenge to do it. But yeah, I think if you just follow a structured history and exam, you can sort of at least try and work out who can be helped and who can't be helped. So the imaging really just confirms it for you. And probably some of the more subtle findings on imaging may not even be relevant. Like if there's no one that's going to be able to treat some of those, like subtle things like, oh, they've got some slight condylar head shape or change, it probably is a little bit irrelevant actually anyway.
Dr. Solak, I'd be interested to know how you guys treat TMDs currently over there in the Highlands, if I'm not mistaken, you're over there, and how you treat trismus as well. Because Krish, I was thinking they might benefit from something like Restorabite.
Yeah, so yeah, Restorabite and all that is yeah, I mean they're complex and they're all things. Like the easiest way, if patients have got trismus after a mandibular fracture, what we do in the public hospital here is those little wooden examination sticks, we call them paddle pop sticks because children's ice cream comes on them, right? But you get like 10 of them and you put them in between your teeth or whatever number. So the patient will have a number that they can start with. So if they can fit 5 of them between their teeth, so they're all like stacked up one on top of the other in between your teeth. And then you try and put one extra in between so that you stretch. And the patient knows that number. So it'll be like, say, they did 5, then they got 6 today, then they stopped. Or they got 5, then you stretched it for 10, 15 seconds, you try again, you maybe get to 7 of those little sticks, right? Each stick is about 1.5 millimeters maybe in width. So that means you've opened 8 or 9 millimeters. Then you start again the next day. But if you got to 7, you start at 6 the next day and you try to get to 8. And every day you improve a bit. So that's the sort of low cost option that still happens. Even in our public hospital, that's what we use, because some of these terabyte and all of that is, they're all from America and they're even expensive for our public patients here. So things like those like little paddle pop sticks just to try and get the jaw open is a good idea. And you can either use it in the front of your mouth, but also it's always good to put it on the side of the mouth that you think had the previous trauma or the previous trismus. So if you think it was the right side jaw joint that had the problem, and you would have worked that from the examination, then what you really want is to have those little sticks between your back teeth on the right, like on the same side of the injury.
Yes, I think we have a question.
Hey, good afternoon. Greetings from Kimbe. Sorry, I can't show my face. I'm down with a bad case of cold and flus. Excuse my voice. I'm Beatrice, Dr. Solok, based in West New Britain. That's the new. If you look at the PNG map, the New Guinea Islands, New Britain Island. I'm on the west part of it. So I've had an increasing number of patients with TMD disorders, mostly females. And the way we've been managing is with physical therapy. First thing I do is what I've said, history, examination, check if there's a history of trauma. I usually sit down and have a 30 minutes to 1 hour conversation with the patient. Try to see if there are any other stresses in their lives, if they're students, obviously exams, home situations, include new parents, all those things. Then if I determine there is a psychosocial issue involved, then I call up our mental health and social unit. If it's just if it's trauma, then I do what needs to be done. If it's a fracture, mandibular fracture that involves a TMJ displacement, it's quite difficult then. But as long as I can get the occlusion into place, like normal occlusion, then I would have to reduce the fracture for only 4 weeks, not 6 weeks. Where was I? So physical therapy, I advise patients on how to massage and differentiate from TMJ pain alone and pain from the neck area, from the back, shoulders, because that tells me that there's something else. It's not just TMD pain. Rarely, we've never had surgery done at all. I've had to reduce severe PMJ displacement under general sedation in OT once. I couldn't do it on the chair, but that was mildly successful for a female of 52 years old. X-rays are not very beneficial for me. But basically that covers what I've done for PMD management so far. Thank you.
Thank you very much. That was very insightful. Krish?
Yeah, that sounds all good. Like I think that's going well above and beyond what many dentists would be happy to have a go at here. So that's pretty good.
Thank you.
Do we have any other questions?
Do you have any more questions?
If not, I might invite you to say a few words to sort of close off the night, Jebi.
Oh, yes. First of all, thank you, Dr. Krish. I know you've just finished work, I think around 1. Normally you end surgery at 1 p.m. So thank you for your time. And on behalf of all the Papua New Guinea dental students, and also some of the doctors around Papua New Guinea, I'm so glad to see like doctors from all over the country, from the islands and from the coast joining in. And I believe we've learned a lot from your presentation. And there's quite a lot. I mean, it's quite different. If you could see you're in a developed country and we're in a developing country. And most of the things you're using there are quite advanced. And over here, we're not that advanced yet, but we're using whatever we can for, to help our patients here. But what you've given us is I'm very grateful, and I believe we all enjoyed the presentation. And we're hoping to have some more presentations with you in the future, if that's okay with you.
Yeah, love to. Thank you for having me.
Thank you.
I'll just echo Jebi's words there. Krish, thank you so much for taking the time after surgery to give the lecture. And I look forward to future presentations in the new year. Jebi, just on your point about what's available in PNG in the next couple of decades, you and me will bring a lot more services to the people of Papua New Guinea, I have no doubt.
Right.
Thanks, Krish, and we might call it a night.
Thank you.
Thank you, Chris.
Take care. Bye.
Right.